Right, hi everybody. Thanks ever so much for joining our webinar today. It's the long-awaited Q&A with Dr. Gall. We're really grateful to Dr. Gall for giving up his time to do this. As I'm sure everybody is aware, he's extremely busy. So we're really pleased that he's been able to spare the time to do this today. Thanks to everybody for sending in your questions. I think we had maybe something about 200 in total. And whilst I don't think we'll be able to get through 200 questions in the next hour or so, we will do our best to try and answer a broad range of them. We've kind of collated them all together and got topics on the go so that we can try and cover as many bases as possible. So apologies if we don't answer your specific question, but we're going to do our best to help as many people as possible. So without wasting any more time, we will crack on. So hi, Dr. Gall, how are you?
Oh, fine, thank you. Thank you very much for asking me.
No problem. Right then, so the first question is, if COVID patients are developing POTS, how are people with POTS more likely to fare with COVID, or will it make their POTS worse afterwards?
I suppose that the easy answer is that nobody knows, and that is the major problem with a novel disease. I think that we realise that POTS patients will often note an exacerbation, so a worsening of their symptoms with any illness, although it can be rather unpredictable. So some will get worse with a viral illness and others will get over it very quickly. So I think there's no doubt that we've seen quite a number of POTS patients who've picked up COVID and have felt worse. Whether it is worse than another viral illness is actually a little bit difficult to say. So I think we will have to see. I think that, therefore, clearly trying to avoid the infection is the most important, aspect, and doing all of the isolation and face masks and hand washing and all of the standard things are therefore very important for anybody, including POTS patients.
Okay, brilliant, thank you. Does my POTS diagnosis give me any more priority for a vaccine than a normal 40-year-old?
So the short answer is no. What I would say is that the information on the POTS UK website is regularly updated with regards to vaccines and who is at risk and who is not, and who should be receiving the vaccine. So well worth keeping up with those, because I know that the team, put a great deal of effort in making sure that that's up to date. Fortunately, at the moment, the COVID vaccine is indicated for people who are at risk of dying, and that is fortunately not something that we need to worry about in terms of POTS patients.
Okay, fantastic, thank you. I'm concerned to have the COVID vaccine due to allergic reactions, POTS reactions to endless things which I use to control my avoidance and antihistamine. My GP told me that an EpiPen would kill me due to the adrenaline, so I'm always avoiding anything that could trigger anything big. So I believe in this case, I would not be able to have it, which clearly comes with its own concerns. But if enough people have the vaccine, should I be okay anyway?
So obviously, from that perspective, an entirely impossible question to answer. I know, again, as I've said, there's a lot of information on the website about allergic responses. I am aware, and it may be worthwhile in that sort of circumstance, reviewing information on the mast cell activation syndrome websites as well, because obviously that is even more relevant to them. I think clearly there is a balance in that we don't know how people who have significant allergies are going to respond, and nothing can ever be guaranteed. There is absolutely no doubt that POTS patients will feel worse with an EpiPen because it's got adrenaline in it, just in the same way that adrenaline containing local anesthetics will make people feel worse. However, it's not going to kill you. It's just really rather uncomfortable. So it's not a question about, you couldn't have adrenaline if you had a nasty allergic reaction. I mean, clearly, the discussion about if enough people have it, can I pick it up? Then, of course, well, that comes back to all of the discussions right at the beginning of the pandemic on herd immunity. So yes, of course, we would like to feel that herd immunity might make a difference. The difficulty is, of course, that with the vaccines, as I'm sure everybody knows as much about this than I do, we don't know whether the vaccines just prevent you from having a nasty illness. Does it still allow you to pick it up? Could that still worsen your situation? So I think it's very difficult. You're clearly then going to have to rely on, has everybody who I ever meet always been vaccinated? So I think it's enormously difficult. So I think probably the best thing to do is to review what the mast cell activation people say and see what they're recommending, look at what's on the POTS UK website, and then take a view. It's perhaps it would be worthwhile mentioning at this stage, of course, some POTS patients will know that they've developed POTS because of a vaccine. And so, it is entirely possible. So that's not to say that every vaccine causes it, or that everybody's illness has been caused by a vaccine. I think, again, that needs to be emphasised. What it seems with POTS is that often it is an immune stimulus that sets it off. Now, that can be an infection, it can be a vaccination, it can be a pregnancy, it can be an accident, it can be an operation. So it doesn't really matter what. So the point is that we don't know whether even a vaccine might cause people to feel unwell. So there is this balance of, should I be having the illness? Should I be having the vaccine? Which is going to be worse? And the short answer is nobody ever knows. And I can say that we will never, ever know how each person is going to react to all of these immune stimuli.
Okay, brilliant. I think that's a really very difficult question, but a great answer. So thank you very much. And then I think this is our final question on COVID. I think we could easily fill the whole session talking about it, but there are so many unknowns, aren't there? So will any of the research into and awareness of long COVID help with understanding and treatment of POTS, in your opinion?
You would certainly hope so. Obviously, we are all aware that the understanding of POTS is very limited. The research that is going into understanding it is very limited. So if we do know that a proportion of long COVID patients have developed POTS. So that may therefore lead into greater research. We will just have to see. It depends, because it will depend on how much of long COVID is POTS and how much interest therefore there is into pushing that forward. So we will certainly have more patients who will be very interested in getting involved in research, but it comes often with the research, it comes down to the funders. Then whether it will get paid for, we will just have to see.
Okay, brilliant, thank you. Okay then, so moving on now to a different topic. Why is there such a wide range of manifestations with POTS? Some people faint, others don't. Some have sustained tachycardia until they're reclined, whilst others have significant tachycardia that settles more quickly. Why is there such a broad range?
I think there's a broad range because any condition will have different severity. So there will be some people who are only mildly affected. There are some people who are very significantly affected. The biggest and most important aspect of this is that POTS is a syndrome. It says it in its name. What that means is that it's a collection of symptoms. So it's not a disease. So a disease is something where you say, we know what causes this. We can understand the problems, and therefore we can understand the symptoms, and therefore we can understand the treatment. POTS is a syndrome, so it's a collection of symptoms. It may be caused by a number of diseases. Nobody knows. So it's only recognizable on the basis of those symptoms. So it may be that people are different because they actually have different diseases underlying that are producing their symptoms. So that's why it's being very specific about saying, I've got POTS, you've got POTS, why are they not the same? It's because they actually may be two different diseases. Okay, brilliant, thank you.
Why is it so often misdiagnosed as anxiety when symptoms are physical? I've got a few other questions about this, but it was quite a key topic in the questions that came in about the misdiagnosis so often.
Yes, well, I suppose there are a number of aspects to that. So the first thing is that a lot of the symptoms of POTS you will know relate to adrenaline. So there seems to be more adrenaline around, so the heart rate's faster, the blood pressure's more variable, the breathing pattern goes wrong. So it's produced in the same way that anxiety is produced. So it looks and sounds like anxiety. Obviously, people have investigated, are POTS patients any more anxious than anybody else? And the general feeling is no. The difficulty, of course, is that we know that POTS is more likely to affect younger women. We don't know why. We presume that there's hormonal influences in that. We presume that autoimmune influences will be relevant, because that's just younger women have more autoimmune problems. But unfortunately, the world out there just thinks you're anxious. So doctors decided years and years and years and years and years ago that young women are anxious. And so without understanding the disease completely, if somebody presents with these symptoms, then their first thought will be, I wonder whether it's anxiety. And the problem is that modern medicine has focused on a number of these illnesses and said, look, we can't find an explanation. And therefore we wonder whether anxiety is the explanation. And it's become a little bit easy just to say, well, it's probably anxiety then. And the biggest problem comes back to the COVID comment about POTS doesn't kill you. If POTS was a disease that caused death, people would have focused on it. The fact that it just makes you feel ill, but it doesn't kill you, means that therefore people are less likely to focus on it. So if it doesn't do you serious damage, now when I say serious, I mean I'm not minimizing the symptoms. Goodness knows I know how significant they can be, and there are some people who are profoundly affected. But in general terms, unlike a heart attack, POTS doesn't kill you. So it's very easy to ignore. And that's why for years and years and years, it's been possible to ignore it and just label it as anxiety, sort of fitting in with people's preconceptions.
Okay, brilliant. And I think this may well be kind of linked into what you've just said, but why is it that some doctors and cardiologists just won't believe that it's a real syndrome?
I think similarly to what I just said, I think what we have to remember is that it is not, modern medicine works on the principle of I need to see it, I must be able to measure it. So we've got wonderful scans that we can image the heart to enormous detail, but POTS doesn't affect heart structure. It doesn't narrow blood vessels. It doesn't cause a funny rhythm. What it is an abnormality in the regulation of the heart and the lung system, we think. So what that means is that what you're not looking for is damage to the heart. You're looking to see, well, actually, it's faster than it should be. The blood pressure's lower than it should be. The breathing pattern is wrong. So the problem is that because it's an abnormality in the regulation and there isn't a sort of structural or a rhythm disturbance, it's then much more easy to miss it. Because actually, if you look at medical textbooks, they don't talk about abnormalities in the regulation of systems. They talk about structure and blockage. And it's not just cardiologists. So if you talk to gastroenterologists about tummy things, you'll find the same thing. They're focused on blockages and ulcers and that sort of thing. And similarly in the bladder, and similarly in the brain, and similarly all over the body. So we're interested in structural abnormalities. We haven't been interested in the way that organ systems function and when that function goes wrong. And that's why it's been very easy to miss. And actually, where it also comes down to, you will not find POTS, in a lot of medical textbooks. And a lot of the time that doctors have qualified, it wasn't a disease when they qualified. So it's if it's not very well recognized and it's a bit difficult to pin down and nobody quite knows about it, then it becomes very easy to ignore it as I'm not even sure that it's real. And part of the problem then is that some patients, very frustrated, will say, good, right, I'm going to go and see a doctor privately. I can't get to see somebody on the NHS, so I'm going to go and see somebody privately. I've been honoured to see a number of patients like that myself. But then that, sometimes that feeds in. They say, oh, well, yeah, but you just paid to get somebody to give you an opinion. Well, you can pay to get anything done. So again, it comes back to the preconceptions. Everybody has these preconceptions about whether it's real or not. And it can then become extremely difficult to change people's minds.
Yeah.
And coming back to one of the previous things we said, it may be that COVID changes that.
Yeah.
Suddenly, it's not actually just a few people coming along saying, actually, I've got a problem, and it's easy to ignore. Suddenly, you've got a huge number of people coming along with a problem that you absolutely can't ignore, and it's then in national guidelines. And of course, POTS UK had a representative on the long COVID NICE committee, which is why POTS is in there. So we may learn more, we may get it out there because of that.
Yeah, let's hope so. I mean, we need to take some positives out of this awful situation, don't we? So that would certainly be a good one. Okay, thank you very much. Okay, this is quite a long question, but I think it will be quite relevant to lots of people. So this parent said, I believe my 14-year-old son has POTS and EDS. They have a finger oxygen pulse monitor at home that shows that his heart rate increases between 40 to 60 beats per minute from lying to standing. What other information can this parent put together at home whilst waiting for his symptoms to be investigated that would help the professionals when they eventually get to see them? He isn't able to be seen by a GP currently due to do routine obs due to COVID. And this parent's put that they're very happy to purchase more equipment to help monitor him, like a blood pressure machine and that sort of thing. Is there anything people can do at home that would help when you go to your doctor to kind of present your case and try and explain it?
Sure. So a common question and interesting and difficult, and obviously what you need will depend on the doctor that you're talking to. And by that, I mean that if they're not going to believe it, they're not going to believe it. Whatever, even if you buy yourself an MRI scanner, it won't make any difference. So what I would say is, so there's some information that is worthwhile. Lots of patients have said, I've taken along the POTS UK information relating to POTS so that the GP can look at it, because some of them will not have come across it. So taking information is helpful. We know that there are guidelines from the Heart Rhythm Society in 2015 and guidelines from the Canadian Cardiovascular Society in 2020 for POTS. So sometimes it might be worthwhile taking that along. So it's not a piece of equipment, it's just information to say, look, this is a real thing. Similarly with the long COVID guidance from NICE. What I would suggest is it's got to be a blood pressure monitor. So you need a blood pressure monitor, something simple and cheap. It doesn't need to be complicated. One that goes on the arm, not one that goes on the wrist, because the ones that go on the wrist are less accurate. And you don't need to spend very much money at all. So a lot of the blood pressure experts might recommend the Omron M2. Other blood pressure monitors are available, as they say. But the idea is that it's very simple and it doesn't cost very much, and then you can do lying and standing blood pressures, because the whole point about POTS is that it's an increase in heart rate but with no change to blood pressure. And so therefore a heart rate monitor doesn't give you any it doesn't give you sufficient information to say POTS. You need that blood pressure. I'm glad you brought it up about the pulse oximeter. Because I am getting overwhelmed with patients telling me about pulse oximeters. Somewhere along the way, pulse oximeters have been suggested to be bought because of the COVID pandemic to look for oxygen levels. Pulse oximeters are inaccurate. They measure the amount of oxygen in your finger. They don't measure the amount of oxygen in the central part of your blood. POTS patients have cold hands. Therefore, you can have very low oxygen levels in your finger, but that has nothing to do with the amount of oxygen levels in your blood. Oxygen levels of 60% on a pulse oximeter are not compatible with life. Therefore, if you are contacting me with an oxygen level of 60%, you are not dead. And, but the problem is that I am getting many emails every single day saying, my oximeter doc tells me that I'm ill. And unfortunately, much as I would love to reply to all of them, it is becoming increasingly impossible to. And we have to realize the limitations. And unfortunately, though some of these wearable technologies are very helpful, they have to be used in the right way. And what's unfortunate about it is that they are more easily purchased than they are easily interpreted. So actually, I think we need to be starting to think about how much of a problem these wearables are, because they are creating more anxiety and more problems and more questions actually than answers.
I think that would be really valuable to a lot of people. I think, we do become so dependent, and just with so much technology, not even health related, we become a bit obsessed by it, don't we? How many steps have we done and all that sort of thing? And I think, what you say about anxiety, I think it can cause so many more issues, can't it? So
yes, absolutely. And what it means is that, you see, if somebody says, my blood pressure was this, my heart rate was this, my watch tells me that it was this, my oxygen levels were this. What you then have to do is you then have to go and see somebody to prove that it wasn't that. You've got to go and see your GP, you've got to go into casualty, you've got to call an ambulance if you really think your oxygen levels are that level. The problem is that they will then say, well, it looks all right, but you'd better contact your specialist. Yeah. And then what we then have to do is to say, well, okay, how can so now I've got to prove that your machine that you bought off Amazon is wrong. So now what tests do I need to do to prove that this cheap non-medical device is actually accurate? And the health service is a little bit overwhelmed at the moment, fortunately less so. So to have to try to prove that these things are inaccurate or whatever was going on, it's increasingly difficult. It's often it is better if people are unwell is to try to see the team in casualty, or try to see the ambulance service, or try to see their GP and say, actually, can you find something with your validated equipment that is a problem?
Yeah. Okay. Well, I mean, that sounds like it's quite a key area at the moment. If you're being kind of absolutely inundated, maybe we could try and work on getting something up onto the website and advertise that on Facebook, just to kind of really highlight it to people that, yes, they need to be aware of that. So
yes, and it's always very difficult, because the Cardia device, which comes in various forms, which can monitor ECG, we've made diagnoses of rhythm disturbances on it. So that's given us the answer, and a lot of the time we use it. So all of these things have to be interpreted. They can be helpful, and there will be lots of people, I'm sure, listening or watching who say, "Oh yes, but my diagnosis was made." But the great difficulty is that it's using non-validated equipment to investigate something and then worrying about it afterwards. That becomes very difficult.
Yeah. Okay. Brilliant. Thank you very much. Okay. Brain fog. There were quite a lot of questions about this. Is there anything that can genuinely help with brain fog? And this particular question, the lady has said that her daughter, or the parent actually said their daughter is in the middle of their A levels and is just struggling so much with brain fog.
Yes. No is the short answer. So the point about it is that we know what you mean by brain fog. We just don't understand where it comes from. We don't understand what it means. People will then worry, or we will suggest, could it relate to the effects of chronic illness, or from pain, from sleep disturbance, from limited amounts of blood getting to the brain, from blood sugar? I think that the problem is that nobody knows. So therefore, is there a drug that improves it? Nobody knows. I think that what we have to think about when it comes to the whole of potsiness and this syndrome is that we sort of get the idea, we have this understanding about what causes the cardiovascular, the heart symptoms of POTS. We can sort of say, we think there's a problem in the regulation of heart rate and blood pressure and blood volume. So that's why people have a fast heart rate, they feel faint, they get breathless, and they get palpitations. So because we understand that, it therefore means, well, I've sort of got some drugs that I can give you that can make a difference to those. So I've got drugs and I understand why it gets better. I can understand why bendy people have joint pains. So therefore we can sort of say, well, to the limits of our understanding, painkillers and physiotherapy might help. We can sort of understand the bowel problems. We can sort of understand the bladder problems. We can sort of understand the migraine problems. And there's lots of treatments for migraines. So there's parts of this syndrome that we can understand and say, I understand that. And there's lots of medicines we can use for that. And that's why that gets better. The problem is that there is also the non-specific stuff. And what that means is that we just don't know where it comes from. And that's brain fog. And that's fatigue.
Yeah.
And nobody understands that. So therefore, understanding what I need to do to make that bit better, actually, we just don't know. So what we have to try to hope is we'll try to treat the bits we can and hope that those other symptoms get better along the way.
Yeah.
And, you know, every now and again, I will talk to somebody who will say, oh, I went on this drug and it was all brilliant. It was fantastic. All the brain fog went. The problem is, that's always different. So, you know, it's not a common event, but somebody will say it's about one thing, somebody says it's about another thing, somebody says it's about another doctor's intervention. So there's nothing specific about it, and that's probably because it means that it's caused, again, by lots of different things.
Yeah.
So that's the nightmare. It's that we just don't understand the cause of the symptom, and therefore to be able to say this is what you need, that becomes then very difficult.
So no magic fix for that one.
No magic fix. Yes, exactly.
Okay. You mentioned fatigue there. We had quite a few questions on fatigue, but because after we asked people to submit their questions, we also had a fatigue webinar hosted by Professor Newton and Victoria Strassheim. So we've kind of excluded those because hopefully those questions will have been covered in that webinar. So if anybody's watching this and thinking, why haven't they answered any questions on that? If you refer back to that, which is on our YouTube channel, then hopefully your answers will be there. There is one on sleep here. Is it common to get adrenaline surges during sleep with POTS, sometimes multiple times a night, and what can be done to help them?
Well, I suppose the first thing to say is that nobody knows what adrenaline surges are. We know what you mean by it, as in everything suddenly seems to go harder and faster. We investigated for adrenaline problems with our endocrinologists for years and never found an adrenaline problem. So it's not, I think, that there is a disease that is giving you too much adrenaline. It will be part of the process. So the way, I think the short answer is nobody knows. Again, the way that I've tended to think about it is that there is just too much adrenaline around in the system. Normal amounts, normal adrenaline, normal system, but just too much of it. So if you are a bit more, so it's more difficult to relax when you sleep, and so it's much easier to wake up. When you wake up, and when I wake up, my heart rate goes up by a little bit, but when you wake up, your heart rate goes up by loads, so you then feel it. Lots of people have then thought, I'm being woken up by my heart going fast. I would suspect that people are being woken up and then their heart goes fast. Okay. You know, so it's the process of waking that then makes it go fast. So it's not that the heart rate going fast is the problem. It's the fact that there's too much adrenaline and it's overreactive. So what do you do about it? I mean, so the sleep people help with various forms of rather complex relaxation. So, you know, there's melatonin to help people sleep. And then there's CBT for insomnia. So there's a particular form of talking therapy that's very good for that. And then it's dampening down that adrenaline. So it's giving people beta blockers. It's giving people ivabradine. So it's giving those medicines that seem to just slow down the heart rate a bit more. And, you know, I know certainly for some patients, it's been very helpful. You know, since you put me on that, I am very much better sort of thing. I don't know that it's the entire answer, but certainly, you know, those medicines can help.
Okay, brilliant. Thank you very much. How can I increase sodium in my diet without adding lots of unhealthy foods?
By adding salts to your diet. so, you know, eat salt. That's the thing to do. So it's not a question necessarily of finding salty foods, but then it could be finding salty foods. You know, to be honest, I mean, some of the discussions in the literature say, well, you could use salt tablets, but salt tablets, some people will find them difficult to tolerate from tummy side effects. I have to say that it's not as common. I do have patients who don't get on with salt tablets, but it's actually not as common as you might think in the guidelines.
Okay.
So, to be honest, what I tend to be doing, if there's not enough salt, and you know, people will know that we do a lot of 24-hour urine collections to measure how much salt goes in and therefore comes out. So we then prescribe salt tablets. And the thing about salt is that it gets into the system very quickly, it retains fluid, and it gives you an immediate boost. So you don't need to be taking weeks and weeks and weeks of salt tablets to make a difference. Lots of patients will go on it and say, within a few days, I'm feeling better. Or, no, I tried the full dose and I didn't feel any different at all. So it's a question of getting enough salt in your diet as quickly and as easily as possible, and sometimes it is just easier just to say, I'm going to take 4 weeks of salt tablets, and if it makes me feel better, brilliant.
Yeah.
The salt tablets we prescribe are much, much stronger in general than the ones you can buy over the counter. I'm never quite convinced by the taking, you know, weighing out some salt at the beginning of the day, because you don't know how much salt you're getting in the diet without measuring it. I'm also not convinced about dissolving salt in orange squash and then drinking it. Now, not to say, and I've got lots of patients who say, yeah, that's what I do. And okay, that's fine. If it works for you, it works for you. We do give salty water to small children to make them sick when they've taken tablets that they shouldn't have done. So, you know, the problem with salty water is that it can make you sick. Now, what you also have to then focus on is what you describe as unhealthy, because obviously remember that the what everybody thought was unhealthy, which was lots of fat. Actually, it may be that lots of carbs is in fact the unhealthy part of all of this. So I think it's a question of, you know, not so many carbs, lots of protein, and if you can get some salt in there, so much the better.
Okay, fab. Thank you very much. Any advice on how to regulate temperature better? Throughout a standard day, I'm either constantly freezing or boiling, and it'll switch between the two in a matter of minutes. It makes me feel awful.
Yes. So I'm afraid I'm going to be facetious and simplistic. Clothes. That's what that's what you do. So, I mean, again, it comes back to those symptoms that we talked about that nobody really understands. So I haven't come across an explanation for why people have poor temperature control, where it's always it's too hot or it's too cold or whatever. Now, I suppose the way to think about it is to say what we think about this condition is that it's an abnormality in the autonomic control of the body. So the way that the brain, using its nerves, controls every part of our bodies that we don't want to have to think about, and that goes slightly wrong. So what you used to have to do, what you didn't used to have to do, which was to think about what the temperature was, because your body would just change, you know, how much you're sweating and how much blood's going to your skin and what your hairs are doing on the back of your arms and so forth, so that the nuances of temperature would be perfectly controlled. It doesn't do that anymore for whatever reason, and so therefore you consciously have to think about it. And that's why it's so difficult, because you're having to consciously think about how your environment is changing on a second-by-second basis and trying to cope with it. So unfortunately, because we don't have an understanding, it is a question of layering. It does sound facetious and silly, I know, but you know, it is a question of saying, right, I'm now too hot, I better take some things off. It is now too cold, I better put some things on. There aren't any hard and fast ways of doing it, unfortunately.
Okay.
But I think that one of the things that when I talk to patients year on year, when they say, yes, I am better than I was, actually, I think that, it's, oh, brilliant. What's the underlying marvel that you discovered? I understand my condition. I know what I need to do. And I think that's unfortunately, a lot of this is now I understand consciously what I need to do to keep myself well.
Yeah. Okay, makes perfect sense. A simple answer, but I think people often are looking for so much more, aren't they? That a different fix. But I suppose that is something that.
Yeah, absolutely, and I think that again is the problem with modern medicine. So just in the same way that the doctors and the other medical staff don't get it because what they want is a simple blood test and a scan that tells them the answer. And I'm afraid, to make the diagnosis, yes, we do have to do tests, but we have to listen to what the patient says, and that takes a while. But of course, modern medicine tells patients that actually what you need is a magic drug, and here's the magic drug, and here's the magic procedure, and it will all go away.
Yeah.
But unfortunately, the magic bullet doesn't exist.
No. So it's not a case of it going away, it's a case of managing it as best you can.
Absolutely. Very much so.
Excellent. It's just giving me an image. I keep putting this jumper on my little boy, and when I pull his jumper off, it really gets stuck on his head. So it's about easy layers, isn't it? Things that aren't difficult to get on and off, that sort of thing.
Yes.
Okay. What exercise programs are available to support those with POTS?
The most complicated exercise program known to man and woman is what's available. So I think that it's a very good question, and it's difficult. So we know that exercise probably is good for POTS patients. So theoretically, what it will do is it will increase the amount of blood in the system, and it will make the heart bigger so it pumps better. And there is some research, as many will know from Dallas, that building up all of those and building up exercise will lead to less POTS symptoms. I think that there are some important messages, however, that come out of that. So the first thing is that they were wondering whether POTS patients in general are deconditioned, as in POTS patients are unfit. Now, unfortunately, that then leads into the usual things about, well, actually what POTS patients are just lazy girls. And obviously, I am paraphrasing. That is not our belief, clearly. And actually, my colleagues at King's have recently published showing that most of our POTS patients, when we studied a small group, actually aren't deconditioned. So we don't think that it's just purely a loss of fitness. The other slight problem with the publications that came out about the exercise program is that they work on the principle that the heart rate increase of 30 is the thing that makes people POTSy. So if your heart rate goes up by more than 30, you've got POTS. If your heart rate goes up by 29, you don't have POTS. Therefore, if an exercise program means that your heart rate no longer goes up above 30, therefore you are cured, that is not accurate. It just means that you are less POTSy. It doesn't mean that you're cured, because it's not all about this heart rate number. Having said that, the exercise program that they used in Dallas does seem to have some benefit. So the whole process of that, and you can find it on the internet, is that it is a small amount of exercise slowly and gradually built up. Now, it's very, very complicated what they did, because it was all part of a research study. And at times it is very difficult to make head nor tail of it, and it will make your brain melt, as it does mine, trying to work out how you do it and your heart rate training zones and all of that sort of side of things. But I think the idea of slow, gradual build-up of exercise, doing a bit today, do I feel all right? Okay, yes, I do feel all right. I'll do a bit more tomorrow. And slowly and gradually building up it as your body can cope with is probably the most important. So rather than necessarily following an exercise regime in enormous detail, though you can find it and you can follow it in enormous detail, I think a slow, gradual build-up of exercise according to how your system can work is the right way of doing it. More horizontal exercise. So that means things like the bikes that you lie down on, swimming, rowing. Obviously, most of those not possible in pandemics, but buying small pedals off your favoured internet retailer and sitting in your armchair and pedaling away for a second, for a minute, for an hour, whatever your system can take, and then doing that little by little is probably the way to do it. And listening to your body so that you do a bit. Am I all right? Oh, I am. Okay, well, let's carry on. Yeah. So and the advantage of those horizontal exercises is that they're also low impact. So they're less likely to smash the joints to pieces. So that's not to say that people can't go running. And I've had lots of patients saying, I've been doing the couch to 5K. That's fine. If it works for you, great. But lots of POTS patients don't like upright exercise. And also there's lots of bendy people out there, and then they will just get painful knees or painful ankles or whatever. So these low impact exercises are then helpful so that people can then build up their exercise.
Yeah. Okay, that makes sense. I think we had quite a few questions as well. What one example is, I'm stuck between a rock and a hard place. I have severe ME and I'm unable to exercise at all. Eating, walking to the toilet, brushing my teeth is about my limit. The exercise is recommended to help POTS. What can I do? So are you, from what you've just said, are you saying like even something, lying down for 1 minute a day and just to build that up, would you still recommend it in those instances?
Yes.
Quite literally a minute a day, and see if you can.
Yes, a minute a day, a second a day, 10 seconds a day, sitting up with your legs down for a few seconds, anything that seems to be some degree of progress.
Okay.
Is important. Now, I mean, there are some times where what we have to do is to give people medications to help their POTS so that they can be upright more, so that they can do more exercise. So sometimes to break the cycle, it's not a question about doing exercise to get better. It's about starting medicines to help people start exercise. But of course, the other thing, as if you've had further discussions with Professor Newton and colleagues, I mean, clearly there is an overlap between chronic fatigue, ME, and POTS. And they're both syndromes, so they're both collections of symptoms. So again, we don't know what causes what. I think that there are clearly POTS patients who have been told they've got chronic fatigue, and so therefore the POTSy stuff, will make a difference. There are people who have chronic fatigue who have got a bit POTSy because they haven't been upright enough. And certainly my colleagues who are doing the exercise testing are starting to recognise two different groups of patients. Some people who are very POTSy, so where the regulation of the heart and the lung system is off, heart's too fast, breathing's wrong, blood pressure's low, but also people where there are metabolic abnormalities, so whether the muscles are not using oxygen well, or that's what they think because nobody knows. So they're looking into that, but what we're wondering is whether that's more of the chronic fatigue ME type of pattern. So what I'm talking about is the management of patients who are POTSy, where you've got POTS. Now, if you've got chronic fatigue ME and your muscles aren't using energy properly, then it may be that, a lot of the standard sort of POTSy stuff is just not going to make a difference because it's actually a different disease underlying. That comes back to the things that we talked about being, these are syndromes, not diseases.
Yeah.
And that becomes very difficult. But I suspect, in the end, that to summarise, small gains. So just a little bit every day, if you can make a difference.
Okay, brilliant. Thank you. Right. I know from personal experience that POTS and its associated conditions such as CFS, ME and EDS can cause anxiety due to worrying about certain symptoms. Have you noticed if any patients who have received counselling or some other form of psychotherapy have had any changes in their symptoms because of it, whether they were better or worse?
So I think the bottom line is, as we are conscious animals, we are going to think about these symptoms, and it's not going to be possible to separate mind and body. So therefore, you are it is entirely acceptable to be made anxious by your symptoms. Therefore, helping somebody deal with the stress and the anxiety of the condition is going to be helpful.
Yeah.
So you know, a lot of the sort of the classical CBT approach of how do I work out how to manage my system better, manage what I do better, think about this in the right way, you know, that is bound to provide benefit for an awful lot of people. I think what's always difficult, however, is that because there still is this differential of people thinking either it's a mind thing or it's a body thing. And so therefore I can have either physical treatments or mind psychological treatments. And if I have both, that doesn't make sense. And, you know, then if whoever you're seeing then says, well, actually, I always thought this was a psychological condition. Now you're getting better with CBT. I always knew you were mad. You know, so sometimes I think people don't necessarily quite, you know, they don't want to go down that line because of the concern that people will then say, I always knew you were mad. So it then becomes labelled as a psychological problem.
Yeah.
And then, of course, you know, I have heard from patients that people will have, you know, some therapists, psychiatrists or psychologists or whoever, who take a very psychological view of the condition. There's nothing physically wrong with you, it's all in your mind. So looking after yourself and the way that how you think about things has to be a benefit.
Yeah.
And it has to be a benefit for anybody with an illness, and certainly with a chronic illness, and certainly in a younger person, you know, that has such wide-ranging effects. But there is a certain element of some difficulty in accessing it for all of these sorts of reasons.
Okay, brilliant. Thank you very much. Why is IV saline therapy more commonly used in the USA for severely affected patients, and why isn't it used in the UK more than it is?
So very simply, you can get what you want to pay for in the States. If you want it, you can pay for it. Whether it's the right thing doesn't matter, you can pay for it. So intravenous fluids are a very simple way of filling up the blood vessels. And we know, and it's in the guidelines, that if somebody is very unwell, that going to casualty and having some fluid will actually help them feel better. And you can go to the Heart Rhythm Society guidelines for the management of POTS 2015. You can download it off the internet and it says it there. And you can see it, and you can take it along to casualty and say, there, see, I'm feeling rubbish. The problem with giving IV fluids chronically is that you have to have plastic tubes in your vein chronically. Anybody who has ever seen a patient who is awaiting a renal transplant, who has plastic tubes in themselves chronically, will know that they recurrently get infected, that it blocks off veins, that you only have a limited number of veins, that when that gets infected, that can then make you septic. When it gets infected, it can infect your heart, and then you can get very seriously ill and die from the infection that it produces. Therefore, chronic intravenous fluid therapy is dangerous, which is why acute therapy in the guidelines is agreed as a great thing to do. Chronic comes under the class 3 indication, which is everybody agrees that this is a thing not to do because it is long-term dangerous. The other reasons for it, or the time where it becomes relevant, is for the small number of POTS patients where their bowel function becomes very significantly impaired and actually they can't take enough food and fluid in orally, and so they are losing weight and becoming malnourished. And in that circumstance, then the gastroenterologists and the nutrition teams then get involved, and not only are giving intravenous food, but they can also give intravenous fluid. And then we advise, well, actually, it would be a good idea to give more fluid in that circumstance. those gastroenterologists are set up with an IV nutrition team to be able to manage that. So they have a system in place to do all the regular blood tests, to send out the fluids to you, to send out the fluids, the food, to have the nurses who will visit you at home. So when the bowels don't work, or when the stomach doesn't work, then there are systems in place to do it. But unfortunately, the risks associated with chronic intravenous fluids are so enormous that it's just not something that we get involved in.
Okay, brilliant. Thank you very much. We had quite a few questions on pregnancy and childbirth and that kind of thing. It came up a lot in our recent POTS UK survey. There was lots of questions and a desire for a webinar on pregnancy. So we are going to try and deliver that. We haven't got anything planned at the moment, but we are looking into trying to get something like that done. But just one question on it. Have you got any advice on the best way to deliver a baby, whether that be C-section or a natural birth, for a woman who has POTS and vasovagal syncope? She's been given different advice in the past about what the best way is to do it, and she just wanted to know your view.
Sure. So my view is nothing to do with me, Gov. Joking apart, it is absolutely not for the cardiologist to define how a baby should be delivered. I do know that the pregnancy information on the POTS UK website has been updated. That's written by Professor Nelson Piercy and her colleague. She's a professor of obstetric medicine at St Thomas's, and therefore knows more about the POTS effects and how that interacts with pregnancy than anybody else. So what she says goes. And the general message is that you manage the pregnancy and the delivery in the same way as you would normally do it. So the general feeling is that if a caesarean is indicated for an obstetric reason, then patients have a caesarean. But the general feeling seems to be that patients should opt for natural births rather than doctor-induced births. And I don't mean induction. What I'm saying is that you do everything naturally as the obstetricians advise, but you don't need to do anything more complicated than normal. Now, whether having a home water birth is a very good idea in a POTS patient, I would probably suggest no. It's better to have the baby in hospital, and that often Professor Nelson Piercy would suggest that. But you certainly don't need to have a caesarean on our account.
Okay.
And what we would often do, or what is often suggested, is that the obstetricians need to be involved, and the obstetricians, if they have questions, can address those to Professor Nelson Piercy. And as far as I'm aware, she is able to provide information. She's written a review article in their journal, and so she often forwards that to people. So we don't want to make it any more complicated than it needs to be.
Okay, brilliant, thank you. Right, I'm going to try and squeeze in two last questions. The first one is, can POTS be inherited from your parents?
So the short answer is nobody knows. Now, so we have absolutely no idea. There is certainly, it does seem to run in families. The question is, does it run in families because of hypermobility? And there is certainly a suggestion that hypermobility runs in families. The problem, of course, with that is that the common form of hypermobility, nobody knows the genetic abnormalities. So we suspect that it probably does run in families, probably because of the hypermobility, but there's absolutely no certainty to it. And I suppose the only messages that really come out of it are, so some of our patients will then say, they'll look back and say, oh yeah, mum or granny, yes, they've always had those funny symptoms, isn't it interesting? And perhaps you then look out for your children's symptoms and then say, oh, I wonder whether some of their symptoms are relevant. And so you don't have the 7 years to get a diagnosis for them that you might have had, sort of thing. So forewarned is forearmed. so we think it probably is to some extent, but how that helps, is perhaps uncertain.
Okay, brilliant. We've got time for one last one.
Yeah, absolutely.
Once you have stabilised your symptoms with medication, do you feel it's possible to come off them or at least reduce them in the future? This person's hoping that once her more debilitating symptoms are under control through medication, it might be easier to make some specific lifestyle changes such as exercise and diet, which then might mean that she can reduce her dependency on medication.
Yeah, so absolutely. But of course, nobody knows. Which is the general answer with everything to do with POTS. If you have a question, just say nobody knows, and that's the answer. I think that because we don't understand it, but what we think it is probably some subtle effects on the nerve control of the organ systems. Some of that effect may improve with time. Some of that won't improve with time, but we just don't know how much. Some of that will be improved because of the lifestyle changes you institute. Some of that will improve because of the help that we give, whether that's medications or physiotherapy or whatever it happens to be. So yes, what we hope is that we give medicines and that helps you feel better so that you can do more. And the more you do, the better you get. It might be that you have to keep taking the medicines to keep yourself well so that you can keep yourself well, and that keeps you then stable. It is possible that then you get so much better that you can then reduce the medicines. And obviously, I will say to lots of our patients, you can vary the dose according to how you feel, because all of the medicines that we use tend to be, changeable in that manner. So yes, in the long term, we would rather you weren't taking medications, because obviously they have their long-term downsides and their side effects and their interactions. So that's the hope, but whether it happens, nobody knows, and it is very much going to be a question of how much underlying problem there is, how much of it gets better, and how much you can influence by the lifestyle changes.
Okay, brilliant. Well, I think we'll leave it there. I know you've still got a very busy day ahead of you. So again, on behalf of everybody at POTS UK, thank you so much for giving up your time to do that today. I think it's going to be hugely helpful to people, and I know it's going to be well watched very quickly by many. So thank you very much. Is there anything else you want to add? Any points that you want to clarify or anything further before we end the session?
I think that's fine.
Okay, brilliant. Well, thanks
Thank you
ever
very
so
much
much.
indeed.
Take care.
Great.
Bye-bye.
All the best.
Thank you. Bye.